So today's topic is about infective endocarditis and a small portion of pericarditis we will cover. Okay. So anyone, what is endocarditis? Inflammation of endocardial muscle or tissues. Okay, what by the term you know. Okay, so we'll go through the definition, we'll go through the etiology, we'll go through the types, pathogenesis, morphologic features, diagnostic criteria, complications, and lastly we'll see about pericarditis. Okay. So first, coming to the definition. So what is infective endocarditis? It is a microbial infection of the heart valves. Okay. So how many valves are there in our heart? What are the names? Mitral valve, tricuspid valve, two semilunar valves. Okay. So mainly it will affect the tricuspid valve, mitral valves. Okay. So these are the microbial infection of the heart valves or the mural endocardium. What is mural endocardium? This is the inner endothelial lining of the myocardium. Okay. That leads to the formation of, the main important word is vegetation. Okay. So they will form something which is known as vegetations, which is composed of thrombotic debris. Okay. So what these debris are made up of? They are made up of thrombin, platelet plug, all these things along with some of the microorganisms. Okay. So there will be thrombotic debris as well as there will be organisms which will be often, and what ultimately they will do? They will destruct the underlying tissue. Okay. So this is the exact definition of infective endocarditis. Okay. So as you can see in this diagram, so this is the cross section of the heart. So this is the normal aortic valve. So here you can see these are the vegetations, or this is the affected valve, aortic valve, where you can see the vegetations. Okay. So this is, we can tell it as infective endocarditis. It is mostly you can see in medicine, in clinics where you go. In pathology it's important, but more you will get to know in clinics patients. Okay. So mainly what are the etiology? Everywhere it's strep, staphylo, all this. So apart from strep and staphylo, one more group is there known as HACEK group. Okay. So from Streptococcus viridans, so they will infect the native valve. Okay. But previously damaged, or so mainly Streptococcus, then staph, and then Enterococci and HACEK group. What are the HACEK group is there? Haemophilus, Acinetobacillus, Cardiobacterium, Echinella and Kingerella. Okay. So this one is the most important. Okay. So apart from strep and staphylo, this HACEK group is one more important. Okay, among the etiology. So next is predisposing factors. So this is one of the etiology, this infective agents. Next is predisposing factors. So there are three main types. What are these? These are conditions which initiate bacteremia, septicemia and pyemia, and then underlying heart disease. And third one is the impaired host defenses. So one by one we'll go. So from where this actually is coming, from where we are getting these heart valve infections? Have you ever wondered? From one particular tooth extraction we can get that. Okay. So if any, in case of any dental extraction, in case of any periodontal surgery, tooth brushing also we can get, tonsillectomy, any respiratory, genitourinary, GI mucosa tract infection or esophageal dilation, also we can get this type of infection. Okay. From there it is the entry point of the infection. Okay, clear? Next is any underlying heart disease. Okay, so in case of chronic rheumatic valvular disease, you can get in 50% of the cases. In congenital heart disease, you can get in 20% of the cases. So in congenital heart disease, what this include? This include VSD. What is VSD? Ventricular septal defect. Then subaortic stenosis, pulmonary stenosis, bicuspid aortic valve coarctation, and PDA. Okay, what is PDA? Patent ductus arteriosus. Okay, and in others, what we can get is syphilitic aortic valve disease, atherosclerotic valvular disease, floppy mitral valve, and prosthetic heart valves. Okay, so these are the some other etiologies from where you can get. The third one is impaired host defenses. So finally, what will happen if the patient or if the person is having the host defense impaired? Okay, so if we are having low immunity, we can get that. Okay, so in case of any lymphoma, in case of any leukemia, we can get this. Then in case of cytotoxic therapy for cancers like chemotherapy, radiotherapy, then in transplant patients, then deficient functions of neutrophils and macrophages, we can get this infective endocarditis. Okay, clear about the etiologies? Okay, so coming to the types. Okay, so what are the types? It is of two types. Okay, first is acute and then is subacute. It is not chronic, so it will be subacute. Okay, so acute means it will affect the normal valve. Acute, you know, as it is happening then and then, so it will affect the normal valve. So it won't affect the previously affected valve, so it will affect only the normal valve. Okay, and it will be rapidly destructive. Okay, so it will affect the normal valves and then it is rapidly destructive. Okay, then it will have a metastatic foci. Then mostly the common organism will be staph, and then if it is not treated, it will be usually fatal within 6 weeks. Okay, clear? Then little opposite will be the subacute. So it will often affect the damaged heart valves. Okay, subacute. Then it will be indolent in nature, and if it is not treated, it will be fatal by, it will take time, but it will be fatal almost by 1 year. Okay, clear? So this is one distinguishing feature. Duration of acute will be less than 6 weeks. Subacute will be more than 6 weeks. Most common organism will be staph, streptococci. Here it will be Streptococcus viridans. Then virulence of the organisms. In acute it will be highly virulent, and in case of subacute it will be less virulent. In previously it will affect the previously affected valves, and it will be, I think it won't. Okay, usually previously damaged valves, it will, yeah, it will affect the previously normal valves and it will be affecting the previously damaged valves. Okay, then the lesions on the valves, these are invasive, destructive as well as suppurative. Okay, and this will be usually not invasive or suppurative. Clinical features we will see in the later slides. Okay, so what is the pathogenesis? So how they enter? So bacteria causing bacterial endocarditis on entering the bloodstream are implanted on the cardiac valves or the mural endocardium. So directly they will go to the mural endocardium. Because why, how they goes? Because they have surface adhesion molecule. Okay, so because of the surface adhesion molecule, they mediate adherence to the injured endocardium. Okay, so this is how the bacteria enters the endocardium. Okay, So there are several predisposing factors which develops the bacterial implants development, okay. So first is the circulating bacteria lodges much more frequently on the previously damaged valves from diseases, chiefly the rheumatic heart disease, congenital heart disease and prosthetic valves, then on the healthy valves. Anything, it will affect the previously damaged valves, not on the normal things, okay. Second one is conditions producing the hemodynamic stress on the valves are liable to cause damage to the endothelium, favoring formation of platelet fibrin thrombi which gets infected from the circulating bacteria, okay. So what they will do? They will produce one hemodynamic stress and ultimately they will in the valve. Where they will produce the hemodynamic stress? They will produce in the valves, okay. And they will ultimately form the platelet fibrin thrombi there, and ultimately that adhesion molecule, their platelet will come, thrombi will come and bacteria will enter, there only they will get damaged, okay. All the three things will come and damage the valve there, okay. Another alternative hypothesis is the occurrence of non-bacterial thrombotic endocarditis, that is NBTE, okay, from prolonged stress which results in the following bacterial contamination, okay. So what are the morphological features? So as I already told, though it is acute or subacute, the main thing what you can get in infective endocarditis is vegetations, okay. So what are these vegetations? They are the classical hallmark of infective endocarditis. What are they? They are friable, okay. What I have told once in class, what is friable? Easily breakable, good. Then it is bulky, potentially destructive lesions containing fibrin, inflammatory cells, bacteria or other organisms. So if someone asks what is vegetation, you have to tell this. These are friable, these are bulky, potentially destructive lesion containing fibrin, inflammatory cell, bacteria and other organisms, okay. Clear? So the most common valve affected is the aortic and mitral valve, okay. Then the vegetations, it can be single, it can be multiple. And what will happen from the vegetation? They can occasionally erode into the underlying myocardium and they can produce one abscess too, okay. So these vegetations are prone to embolization. So vegetations are not the problem. Problem is when embolization is occurring, they can block and patient can collapse, okay. So these embolic fragments may contain the virulent organisms too, okay. Abscesses frequently develop where they lodge and they leads to septic infarcts too, okay. So these are very important, all the points in the morphological features. If infective endocarditis is coming, you have to write all these things, okay. So here in this diagram you can see, this is the heart, cross section of the heart. See, can you see the red color? Can you appreciate the arrows here? So these are all infected mitral valve, okay. Here they have written, it's like they are caused by Streptococcus viridans. You have to do culture and in the organism here, okay. So they are large friable vegetations. Here you can see these are very bulky, large friable vegetations, and here you can see this is a subacute type, and here you can see it can form to the abscess formation too, okay. They form the destructive rings type. Can you see? They have formed ring, okay. So this is acute, this one is subacute, okay. So microscopically the vegetations in bacterial endocarditis consists of 3 zones, okay. So outer layer or the cap consists of eosinophilic material composed of fibrin and platelets. First zone. This is the outer. Then beneath that is the layer basophilic zone containing the bacteria. Then the third layer, that is the deeper layer, consists of non-specific inflammatory reactions in the cusps itself, and in case of subacute there may be evidence of repair too, okay, because it is subacute there can be repair also happening. So the first layer will be of eosinophilic material, second layer there will be full of bacteria, and the third layer will be non-specific inflammatory reactions, okay. In this diagram it's not that clear, but then also you can see in the middle it's full of inflammatory. See the chronic inflammatory infiltrates, all the blue dots you can see that these are all lymphocytes, and these are all newly formed capillaries you can see here. I don't think you can appreciate, but at least for the diagram you can refer to this diagram. I think I have taken this from Harsh Mohan. So what are the clinical features? Mainly they will present with, if anyone is having bacterial infection, they will present mainly with fever, okay. So most common presentation will be of fever. Then there will be anorexia, there will be weight loss, there will be night sweats, there will be malaise, heart murmur, petechiae will be there on the skin, conjunctiva, oral mucosa. Some patients might complain of splenomegaly too, okay. And numerous complaints will be there, but these are some of the important clinical features you have to know, okay. This one is very important diagnostic criteria, that is modified Duke's criteria for infective endocarditis, okay. So first one is pathologic criteria, okay. What is the pathologic criteria? So first is microorganisms demonstrated by culture or histologic examination in a vegetation embolus from a vegetation or intracardiac abscess, okay. So you can demonstrate it by culture, as I already told, Streptococcus, Staphylococcus you can't see, okay. You have to do it by culture. You can identify the organism by culture only, okay. So pathologic criteria rely on the culture, okay. If you do culture, where from you will take the culture? You will have to do it from either from the embolus or from the vegetation or from the intracardiac abscess. From any of the three things you can take and you can demonstrate the organism, okay. Then is histological confirmation of active endocarditis in a vegetation or intracardiac abscess. Then you have to histologically confirm it, okay. It's not like that only the culture positive we can give it as infective endocarditis. You can't give it like that. You have to histologically confirm it, okay. So histological confirmation is very important. This is the pathologic criteria. Clear everyone? Next is the clinical criteria. Under clinical criteria, first is major criteria, then there will be minor criteria, okay. So in the major criteria, what are there? So first is blood culture, okay. So blood culture will be positive for characteristic organism or persistently positive for an unusual organism. So then you can, first I have done culture from the vegetations, okay, but here we are doing the blood culture, okay. So blood culture we are doing to find the characteristic organism, what is the main organism here. Then echocardiographic identification of a valve related or implant related oscillating mass or abscess. If you can see, I don't think I have put one picture, but it's there in the book. If you can see there will be mass like in the line of closure you can see the masses of the vegetation. So from there you can see mass or abscess or partial separation of the artificial valves, okay. So it will be echocardiographic identification. It is not any culture or anything, blood culture or anything from the vegetation. So it will be of echocardiographic identification. And third one is new valvular regurgitation. What is regurgitation? Tell. Regurgitation, aortic regurgitation, mitral regurgitation, have you heard? Backflow, okay. So there will be new valvular regurgitation, okay. Then coming to the minor criteria, first is predisposing heart lesion or intravenous drug use. Then is fever. Then is vascular lesions including major arterial emboli, septic pulmonary infarcts, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhages and Janus lesion. These things I will explain later, okay. Then is immunological phenomena including glomerulonephritis, Osler node, rot spot. These things for the vivas are very important. Janus lesion, Osler's node, rot spot. Examiners will ask in viva what are this, okay. I will explain it in the next slides. Then is microbiological evidence including a single culture positive for an unusual organism, okay. So this modified Dukes criteria require either pathological or clinical criteria. If clinical criteria is used, only clinical criteria, not pathological, then 2 major is enough, or else 1 major plus 3 minor, okay, or else 5 minor criteria are used for the definitive diagnosis, okay. So this is very important, either 2 major or 1 major, 3 minor or 5 minor criteria, okay, for a definitive diagnosis. Possible infective endocarditis diagnosis require 1 major, 1 minor or 3 minor, okay. So this is very important, how many criteria required for definitive diagnosis, okay. So can you see what is this? Can you tell just the names I have told just now? Can you appreciate what is this? What? Osler's node, then Janus lesion, then rot spot. So anyone? What? This is Osler's node. This one? This is Janus lesion, okay. So first one is Janus lesion. So what is Janus lesion? These are small erythematous or hemorrhagic macular non-tender lesion. Main important thing is this is non-tender, okay. So this is non-tender lesion on the palms and sole, where you can get only in the palms and soles you will get the Janus lesion and are consequence of septic emboli events, okay. Next one is Osler's node. Why I have told non-tender? Because Osler's node maybe you can't appreciate here, but they are very tender nodules, okay. They are seen in the tip or pulp of the fingertips, okay. So Osler's node are small, tender, subcutaneous nodules that develop in the pulp of the digits or occasionally more proximally in the fingers and persist for hours to several days, okay. Third one is the rot spot. So what you can see here, where it is? Rot spot are seen in the retina, okay. This is in the eye. So they are oval retinal hemorrhages with pale centers, okay. Haven't you seen retinal examination? Clinical postings are going on, na? No eye for now. Ophthalmology posting not start. So rot spot are seen in the retina, okay. These two are mainly seen in the palms and rot spot is mainly seen in the retina, okay. So coming to the complications and sequelae. So these are the cardiac complications. So here you can see mitral valvular stenosis, abscess valve ring, aneurysm, myocardial abscess, pericarditis, all these things. Then you can see non-cardiac and cardiac Here this is one is the cardiac, this one is non-cardiac. So in the brain, lung, spleen, kidney, you can see infarcts and abscesses. And in the skin, you can see petechiae, focal glomerulonephritis, you can see, and Osler's nodes, Janus lesions, all these things you can see as a complications and sequelae too. Clear about infective endocarditis? Nothing much is there. Just to remember, this is the infection of the or inflammation of the cardiac valves. Which valves they are infecting more? Mitral and aortic valve. Okay. So mainly they will be composed of platelet, thrombin and bacteria. What are the common bacteria? Staph, Streptococcus, viridans and one more group I have told, HACEK group. What are the HACEK group? Okay, go and learn all this, okay? HACEK group of organisms, okay? Clear about infective endocarditis? Next, coming to pericarditis. This is a very small topic. So, what is pericarditis? Inflammation of the pericardium, okay? So, it is the inflammation of the pericardial layers and is generally secondary to the disease in the heart or caused by systemic diseases, okay? So, based on the morphologic appearance, pericarditis is classified into acute and chronic types. So, acute pericarditis is of 4 types like serous, fibrinous and serofibrinous, purulent, fibrinopurulent and hemorrhagic pericarditis. Then chronic will be tuberculous, chronic adhesive, chronic constrictive pericardial plugs. Okay? Clear? So first coming to acute pericarditis, which is most frequently encountered. So under that first is serous pericarditis. So these are produced by non-infectious inflammatory disease including rheumatic fever, SLE, scleroderma as well as tumors and uremia. See, these are very boring topics, you have to learn, but you have to learn. These are all theoretical things, okay? Nothing interesting in this kind of topics, but you have to learn, you have to know, because these are very important part of medicine, okay? In medicine every day you have to know all these things. If somebody takes in future medicine, you have to deal with these things, okay? Microscopically what you see? The epicardial and pericardial show infiltration by some neutrophils, lymphocytes. As there is inflammation, there will be inflammatory cells like neutrophils, lymphocytes, all these things, okay? So the fluid usually resolves with the resolution of the underlying disease. So this serous is not a problem, okay? Next one is fibrinous or serofibrinous, okay? So these are the most frequent types of pericarditis and these are composed of serous fluid variably admixed with fibrinous exudate. Commonly caused include myocardial infarction. Then what will be there in the symptoms? There will be sharp pain, pleuritic and it will be position dependent. And there will be fever, congestive failure also may be present. There will be loud pericardial friction rub, which is most specific in case of pericarditis, okay? Third is purulent or suppurative pericarditis. What is that? It reflects an active infection caused by microbial invasion of the pericardial space, okay? Purulent means pus formation, okay? So this can occur through the following. It can occur through direct extension from the neighboring infections, seeding from the blood, lymphatic extension, direct introduction during cardiotomy, and this exudative thing can be of cloudy. Exudate, what is exudate? Okay, pus, what it will consist more? Proteins, okay? So they will be cloudy and there will be frankly pus, and it will be up to 500 ml in volume, and there will be tuberculous pericarditis can exhibit foci of caseation. Okay. So the serosal surfaces are red and granular and coated with the exudate. So in this diagram you can see, what you can see here is bunch of pink bundles. What are this? In histology, pink bundles like structures. Muscle fibers, very good. So these are muscle fibers. So this is, can you see, this is the myocardium. So these are the muscle bundles, okay. This is the pericardium, these are the fibrinous material here, and this is full of eosinophilic material and inflammatory cells, okay. Lymphocytes, eosinophils, all these things will be there. Next, coming to chronic pericarditis. Under chronic, there will be, first one is tuberculous, which is the most frequent form of granulomatous inflammation of the pericardium. The lesion may occur by direct extension from the adjacent foci of tuberculosis, by lymphatic spread from the tracheobronchial lymph node, chronic pulmonary TB, or infected pleura, and this exudate is slightly turbid, okay, caseous or blood stained with sufficient fibrin. Then microscopically, typical tuberculous granuloma with caseation necrosis are seen in the pericardial wall. The lesions generally do not resolve but heal by fibrosis and calcification, okay. So they don't usually resolve. So they will, what they will do, they will heal by fibrosis and they will form calcification, okay. And they will result in chronic constrictive pericarditis. This is the second form. This is chronic adhesive pericarditis. It is the stage of organization and healing by the formation of fibrous adhesion in the pericardium following preceding fibrinous suppurative or hemorrhagic pericarditis. And the third one is chronic constrictive pericarditis, which is a rare condition characterized by dense fibrous or fibrocalcific thickening of the pericardium resulting in mechanical interference with the function of the heart and reduced cardiac output. This just for the name you have to know, okay. It is not like that you have to go through so many things were there under those, but for the name's sake you have to know what are the types of pericarditis, okay. Clear? Anything you want to ask?